Hello, how are you?
Hello.
Everybody's adopted the fuzzy background.
It's like the inside of my head. Just
I
so
must be
fuzzy.
dark. Must be one small pixel of light.
Good afternoon, everybody.
Give everybody another minute or two and then we'll get rolling.
Mm.
12:16, we're gonna go.
Yes, a few people heard you because like 4 people joined all at once.
It's the 12:16 rule. Hey.
Hello.
Hello.
Hey, Chad, I was just going to, unless you wanted to, was just going to get us started with the whole move to the AHP update call discussion. Let me know
All
if
you, I will shut up.
we're ready to start or not. I guess we'll give it a little more time. Looks like people are still coming in.
I said 12:16, that was the rule.
Okay.
You gonna lead off, Renee?
You ready for me to start?
Yeah, fire away. You're in charge.
Great. We want to welcome everyone to what is now the reimagined COVID update call. We did announce to you that we were going to move the cadence of this call monthly. Certainly feeling that the environment called for that. The changes relative to COVID are not coming in at the pace that they used to, and the monthly cadence seemed more appropriate. But at the same time, we were loath to get rid of this audience and loath to get rid of your attention, and we wanted to hold on to the call. So what we've done is we've transitioned obviously to monthly, but we're also going to consider this more generally speaking an AHP update call. That may include, a brief agenda, and it may likely always include a COVID element. And certainly today's iteration of our AHP update call is pretty COVID content heavy. But in future meetings, we want to use this time together to bring you other short, timely bits of updates and information that help you feel engaged in AHP's work, as a forum for you as well to bring any pain points, questions, a call out to your colleagues in the network and other practices for, a call out to them for best practices. We see this as both your forum and our forum that bidirectionally we're going to communicate better and keep you engaged in our work. So I just wanted to make you aware of that change to the content of this meeting. Although I think as we get going today, it'll seem like an AHP COVID update. So I will turn it over to Chad and LJ, and I think we also have some special guest stars that are eagerly anticipated presentation on Paxlavid. So I will shut up.
Perfect. So just to be different, I'm going to talk about monkeypox just for the next hour. That's all I'm going to do. So, Interestingly, in the monkeypox vein, folks probably have seen there's kind of I'll call it slight controversy slash, is this the way we handle outbreaks now? That the CDC has come out and said, you know what, it's probably good to be masking for COVID anyway, but there's also value in masking for monkeypox. And so now that has started an uproar amongst the anti-mask contingent of, oh boy, every time there's something new that comes out, we're all going to be masking for it, immediately. The incidence of monkeypox is still pretty doggone low, but the instance of COVID is still, although we are starting to see a bit of a crest, both regionally and nationally, and we're starting to see a little bit of a downward trend here in the last week or so. We're still averaging in the local area, pretty much by county, 120 to 170 new cases a week kind of thing. So it's not what we were talking about in January, but it's certainly not what we were talking about, say, April, May kind of time frame, when we were starting to really see that kind of plummet and recovery from that surge. So a couple things I would say about COVID in general. There has been much conversation about the slew of Omicron variants. And if you look across the country, there's, the B.A.2, B.A.3, B.A.4. I think we are now all the way out to there's maybe a B.A.7 that are really occurring in very small pockets. And although, there's a little bit of a flurry of information that'll come out to say, oh, there's a new variant that was detected, they're almost like little cluster outbreaks. And if you really start to read, the vast majority of the time, it is just slight deviations in the spike protein configuration. Or, it has features of B.A.2 and B.A.4. And so they classify that as B.A.7. So I say that all to say, folks there are some, kind of, if you follow just popular press, you'd have the opinion that, oh my God, there's a new strain like every week now. And in reality, these are slight deviations of Omicron that are occurring in such small clusters that they don't seem to have the outbreak kind of potential or presence that some of the initial Delta and the initial Omicron variants tended to have. So I say that to say we're not really seeing the genetic drift of the virus the way we were before. There is anticipation that Omicron is going to continue to mutate enough so that perhaps there will need to be an Omicron booster, because we do know that the farther we go, some of the strains don't seem to be behaving as well, I guess I'll say, to the boosters as earlier strains have been. So I would not be surprised as we push towards fall, if there continues to be evidence of genetic drift, that there may in fact be an update to the booster that has led people to say, well, I'm going to delay getting a booster because there's just going to be another one coming. I just don't think we know enough at this point to say that is indeed going to be the case. It certainly, if you back up a couple of months ago, it would have seemed quite likely that there would probably have needed to be a permutation of the booster to accommodate the rapid succession of genetic drift that we were seeing. Now, much like what we would probably expect from a kind of endemic situation where there's not as many people infected and not as much spread as what we were seeing before, we're not seeing the ability of that kind of rapid genetic drift of the virus like we were seeing in going from Delta to Omicron, which were almost kind of two different formulations of the virus to some extent. So because of that, I think the likelihood that we're going to see massive changes in response to the vaccine is probably not likely unless we were to see another surge of a slightly different, and I'm still holding out for COVID pi, because I just think that would be cool to use the Greek alphabet to its fullest extent. But for now, we're still in Omicron, and we're still just calling them subvariants of Omicron. So I have no idea what it takes to go to COVID pi from Omicron, but we're not there yet. That's all I can tell you. The other thing that we kind of sent out special notice about was about the pediatric vaccine. They have opened up for pre-order. That pre-order does not mean that it is approved. In fact, they specifically called out, if you read it in detail, that it is not yet approved and ready for shipment, but they're trying to kind of get ahead of the game. If you had ordered before, there was kind of a Dear Administrator letter that came out from the Department of Health that said you should go ahead and kind of renew that order. That it wouldn't just be, oh, I did it 6 months ago, and so that's forevermore. I will say I can speak from the hospital side. I just got a Dear Administrator letter this morning for noise that was verifying our request for receipt and confirming kind of what shipment would look like when and if the approval came out. So I don't know if that was just a hospital thing, but it does appear that they are kind of getting themselves prepared, anticipating a fairly rapid approval and distribution sequencing. Remember, for this pediatric dose, it's going to be a fractional dose of the adult approved version. So it's not going to be a wholly new vaccine. So that obviously will probably affect the distribution of issues. I don't know, and LJ can speak to, I have not heard yet that there's a different packaging because of the different aliquot. So I know there had been a lot of requests or hope that there would be pre-filled syringes. And I'm pretty sure that that is not the plan at this point, unless LJ knows differently. She came off mute, so maybe y'all just shut up right now.
No, we're just hearing maroon top for the pediatric Pfizer is what has been stated by some of the pharmacists anyway. So, but we have not heard that there will be individual doses, unfortunately.
I know that was kind of the hope and wish and want and desire, but it doesn't seem like we're there yet at this point. Other than that, as far as testing, there has been a bit of a ongoing discussion. Many of you are probably aware in the asymptomatic pre-procedural testing. One, because of the amount of staff time involved. Two, because of the declining incidence and severity of the illness. And three, because we're pretty much taking precautions across the board in the hospital now for pretty much any patient that comes in. So there has been some ongoing conversation about starting to step away from requiring PCR testing for pre-procedural purposes. There is a very likely scenario where we'll be moving to antigen testing on the day of procedure for many cases. In some kind of moderate sedation or less, there has been some conversation about removing pre-procedural testing requirements altogether, just because the prior notice that was sent out by the DOH said you had to be tested within 5 days of your procedure. We all know that if you happen to go to an event, if you tested on Friday and you went to an event this weekend and you have a procedure on Tuesday, it doesn't mean that you're not going to be positive by the time you come in Tuesday for your procedure. So that lead time was probably too long. The DOH came out and then said you have to be tested 24 hours prior to your procedure, and antigen testing could be considered. The problem with that is that the antigen testing still has a false positive, false negative rate of about 10%. So that was pretty high if we were going to be testing, but to do a PCR within 24 hours and have the results back was just logistically a nightmare. So the DOH backed off of that requirement and has now basically come out with a much more watered down version, which is do it within a reasonable period of time. And so that is almost no guidance to some degree. It's more kind of do what you see fit. And I think at least within the U of R, and I think Rochester Regional is kind of partnering with that. We're trying to take kind of that concerted and thoughtful approach that if it's going to be deep sedation and or intubation, probably PCR is preferred, probably, within a couple of days prior to the procedure. But if it is moderate sedation or less, antigen testing is probably sufficient unless PCR is readily available, and probably not getting to the point that we're going to say no testing at all, except for, procedures that are completely benign. Like someone the other day mentioned a sleep study. I'm not sure that necessarily would warrant some special consideration. But those very, very low risk procedures like joint injections and that kind of thing probably don't really need testing at all for something like that. So trying to unify as much as possible. We're meeting again, I believe it's tomorrow, to talk through what that guideline is going to be for some of this lower acuity procedure, both to diminish the strain on the healthcare workforce, but also to kind of right size for the level of risk that we're seeing right now. So you'll be hearing more about that in the coming days. Beyond that, I don't know that there's been a whole lot, but there has been extension of the state of emergency. We've talked about that before. There was recently, from a federal standpoint, an extension of state of emergency specifically around telehealth for behavioral health services. I think that was a 90 or 120-day extension. They did call out in that they thought it was going to be prudent that there be some long-term planning for parity of telehealth at the conclusion of that state of emergency. Now, 90 to 120 days would be in the time frame of where we could be expecting a fall resurgence. So, whether or not the state of emergency is just going to persist indefinitely for a period of time, or whether that was kind of a tip of the hat that we needed to be looking towards what life would be like when the state of emergency expires. It's probably a little bit of both, quite honestly. But for now, I know folks have continued to be concerned about what happens to telehealth when these state of emergencies end. As we've talked about before, everything that we continue to hear is that there is likely to be parity for those visits that are generally construed as being equally acceptably delivered via telehealth. But for instance, a new patient visit or something that was very physical exam dependent, like an orthopedic visit or something like that, that may not be one that maintains parity, because we could probably all agree that would not be a visit that probably should or could be equally conducted remotely. But for right now, it does seem that telehealth likely is here to stay. And both at a federal and local level, there's likely to be ongoing parity, even at the conclusion of the state of emergency. So more to come as we go farther, but we're well kicked out as far as the end date of the state of emergencies at this point. So more to come on that as we get closer. With that, I think I've said pretty much everything I was going to say, so I'll turn it over to LJ for her piece, and then we can go into the Paxlavid talk.
And I can be pretty brief. I think that the only thing to just add is in terms of pediatric vaccination and vaccination in general, I want for everyone to be aware that we've heard that the state vaccination site is closing next week. The state site in our region is closing next week. So it's really important, if anybody has been sending their patients for boosters or anything else that direction, that will not be available. We knew coming into this that the state site and the county sites and the pharmacies would not be vaccinating for the little kids, which is why you all have been extensively preparing to be ready to do that in the practice setting. We'll send out some reminders and updates. There have been some sent already about, as Chad alluded to, ordering your vaccine. There'll be information coming out to finalize the coding and billing for those new vaccines. And we also have asked for the team from Common Ground Health to revamp and revise their parent and family or caregiver information around COVID vaccination for younger children. You'll remember they had a really nice infographic that was put together, translated into multiple languages. So we're asking for that to be re-upped for next week. I also know that the Colorado Children's Hospital team with pediatric infectious disease, Dr. Nayak is with us today, that they've been working on an FAQ around the vaccine for the little kids. So we will push all this information out to you and update it on our website as it becomes available. If you're having any difficulty, you thought you were ready to vaccinate, you're not ready to vaccinate, you're having any difficulty with ordering, please reach out to myself or to Jana. We want to make sure that everyone is ready. We recognize that our uptake is probably going to be in the 20% range if we're lucky in the very beginning. But for those people who've been waiting for a long time, a very long time, to vaccinate their younger kids, they are going to want to be able to get in quickly. So we want to do everything we can to help your practice be efficient in responding to your patients and their families. So that's the one thing on vaccination. wanted to just add that we will also be putting up on our website the latest Department of Health revised isolation and quarantine guidance. I'll be honest with you, I'm not going to go through this in detail right now because somehow the health department has to figure out a way to summarize very succinctly what the changes are. I keep weeding through and trying to compare. Essentially, the most of the changes here are allowing some minor exception in the pre-K school-aged age group for kids to not have to be in quarantine while they're in school, provided there's testing that's done. For the littlest kids, much of this is all the same, but I think they're waiting on revamping all of this guidance until the vaccine is released, because then I think we're going to get the most revised guidance over the summer for the fall. But we will re-up this with a couple of bullets just to orient you to what's helpful. You'll remember, I still feel like we're caught in math word problem land. You remember when we used to talk about, the math word problem, this kid was exposed 6 days ago and now they have this and X and Y, Z. And we found this amazing chart, which of course with my blurred screen, you can't see. The chart has been updated. So when you're confused, my take is go to the chart that we'll put up on the website. Most of you will have already received this from the county. It came out right at the beginning of this month. So I wanted to call your attention to that. And then just one last thing around testing, wanted to be sure that our teams were aware that the COVID sample swabbing site that was set up initially in response to assuring that kids could get in quickly for COVID testing in order to stay in school and keep schools open. You'll remember that was set up at White Spruce. And then it morphed into a site that was screening adults as well as kids for PCR testing. That site has closed as of this week. The volume just wasn't what was needed. I know that a few of our primary care practices were referring on occasion, but they were down to doing, less than 10 patients in any given day. And so since accessibility is out there in other spaces, many of you have testing available in your practice. And then of course the antigen testing is accepted. That has actually shut down now. I'll just give a shout out. I don't know if any of that team is on here, but they did a really nice job in being responsive to the need of the community and was helpful at that time. And so then I think we're going to turn it over now to the pharmacy team. Jana, do you want to do the honors?
Well, we have the pharmacy team here to present on COVID-19 on mild and moderate use of Paxlavid in pediatric populations. Katie, I've got the slide deck up. I'm going to share my screen now for you guys to get started. Just let me know when you want me to advance the slides.
Sure. Thank you for inviting us to give you an update on pediatric medication options. And we have Dr. Nayak here as well. So Katie's going to give us a quick overview of the pediatric options that we have available for right now. And then Janine Vinzi, our senior clinical pharmacy specialist with primary care, will give another update and we'll facilitate a question and answer time with Dr. Nayak.
All right, thanks, Bob. So like Gina said, I am going to present on just a really brief presentation on pediatric treatment options for mild to moderate COVID-19. So the preferred treatment option in peds, like adults, is Paxlavid. The active drug in Paxlavid is nirmatrelvir, which blocks the activity of the SARS-CoV-2 3CL protease, which is an enzyme required for viral replication. The second component of Paxlavid is ritonavir, which is a pharmacokinetic booster that slows the metabolism of nirmatrelvir, so it remains active in the body for longer, pretty much. So, and ritonavir is a potent CYP3A4 inhibitor, which is why there are so many drug interactions. We'll go to the next slide. So Paxlavid is authorized for emergency use in non-hospitalized pediatric patients age greater than 12 and weighing more than 40 kilograms with mild to moderate symptoms who are considered high risk for progression to severe disease. So there's a whole list here from the CDC of what would put you at higher risk for severe COVID-19. But the most common factors in peds include diabetes, being overweight, chronic lung disease, including asthma, immunosuppressive diseases, or if you're on immunosuppressive treatment, cardiovascular disease, sickle cell disease, if the patient has neurodevelopmental disorders or dependence on medical technology. Those are the most pertinent ones for pediatrics. Next slide. So Paxlavid must be initiated within 5 days of symptom onset, which I'm sure a lot of you know already. It's also important that you counsel parents on how their child should take this drug. So it's 3 tablets per dose, which includes 2 nirmatrelvir tablets and 1 ritonavir tablet per dose. So it's actually 3 tablets twice a day for 5 days. Paxlavid does not decrease the duration of symptoms, but it has been shown to reduce the risk of hospitalization and death through day 28 by 88% compared to placebo. So that ends up being a number needed to treat of 19. It's important to note that pediatric patients were actually not included in these trials, and that the data was actually just extrapolated based on weight. Paxlavid was also not studied in vaccinated patients, and it's not authorized for pre-exposure or post-exposure prophylaxis. Overall, it is generally well tolerated. Next slide. So Paxlavid does need to be renally dose adjusted, and it's not recommended in severe hepatic impairment. You can see it there. Mostly on the slide, I want to talk about that there is a potential for rebound cases, which I'm sure you've heard as well, of COVID-19 following completion of a 5-day course of Paxlavid treatment. The symptoms that patients develop during their rebound case are generally mild. And the current recommendation in rebound cases is to not retreat with Paxlavid. However, these kids do need to repeat their isolation period. So before I move on to the other treatment options, I just want to reiterate that when deciding to treat or not to treat pediatric patients 12 years or older with Paxlavid, you must first consider their vaccination status, their immune status, and the presence of these risk factors for clinical progression to severe disease to ensure that we're using this medication appropriately in the population. Okay, you can go to the next slide. So I'll only briefly discuss the next 3 treatment options. Molnupiravir is a nucleoside analog that inhibits SARS-CoV-2 replication, and it's dosed as 4 200 milligram tablets every 12 hours for 5 days. You can go to the next slide. So Molnupiravir is approved for individuals 18 years and older, so different than Paxlavid. It's considered second line and is contraindicated during pregnancy and lactation. It is generally well tolerated, but the most important thing is that females of childbearing potential need to use reliable contraception during and for 4 days following therapy, and males have to use a reliable method for at least 3 months following therapy. Next slide. Remdesivir is approved for hospitalized or non-hospitalized high-risk pediatric patients 28 days of age and older and weigh more than 3 kilograms. So dosing does change depending upon weight. Remdesivir in the inpatient setting does require a 3-day hospital admission. Just so you know, and have all the kind of dosing listed there for at least if you're over 40 kilograms, the dose, like I said, is different if you're less than that. The most common side effects are listed here for you to read. Data for the approval of remdesivir is based on viral load as opposed to the prevention of hospitalization or death. Use in non-hospitalized patients is pretty limited as remdesivir is only available for IV infusion. I'm not aware of any home care agencies that are giving this at the moment, but would need to double check that. And then lastly, Babtalovamab is a monoclonal antibody administered by IV infusion under EUA. for individuals at least 12 years or older, and it must be started within 7 days of symptom onset. And this monoclonal antibody treatment is considered last line due to its lack of efficacy data against all these emerging variants. And that was it. I just wanted to give a very brief description. You may have known a lot of that already, but now I'll turn it over to Janine, who will facilitate a question and answer session with Dr. Nayak.
Thanks, Katie. So those of you who don't know Dr. Nayak, she is an infectious disease pediatric specialist at URMC, and we invited her today to speak on her experience with using Paxlavid. I know she's received a number of calls from members of the community kind of asking, who is this appropriate for, how to incorporate this into the practice, and what needs to be considered while you're doing that. So I'll turn it over to her. Just, maybe she can offer a few pearls, and then if you have questions, if you don't mind putting them in the chat, we can run through those as well.
Hi, thanks so much for having me on the call today. The first thing I wanted to quickly comment upon is in terms of the variant emergence, just to second what Dr. Teeters had said, this is something that as a flu, well, I guess now COVID researcher too, but as a flu researcher, this is something that always happened in flu. You had variant after variant after variant emerge. The only difference is it wasn't broadcast all over CNN and the 24-hour news cycle. So this is nothing that is surprising at all. As far as Paxlavid, I think the treatment recommendations have been changing relatively rapidly with the loss of most of the monoclonal antibodies that were available, including, Bamedi, which we could use down to infants. The difficult thing that we often run into is when you're talking about kids under 12, there really are not a lot of treatment options available. And this is, right now, very unfortunate. There are clinical trials underway to bring Paxlavid down to the younger age groups who have high risk factors, but it is not a reality yet. Remdesivir is an option, but it's very difficult because of the availability only of IV infusion. That is something we've considered in kids who seem to be getting more sick quickly, but right now it does essentially require an inpatient admission. I'm more than happy to address any questions that you guys might have about COVID treatment in children. Most of the calls that I have received from the community have been kids who people are inquiring about use of monoclonal antibodies. And a lot of them are potentially eligible for Paxlavid. So I've sent out a lot of the Paxlavid information to primary care physicians and said, how about considering this? The one thing I would implore people, and I believe this was brought up in the presentation, but just check drug interactions. There are a lot of medication interactions. For most kids, this is not an issue. However, kids who are, high risk may be on immunosuppressives or other drugs that will interact with Paxlavid, and that is a potential problem. So just remember to either check yourself or reach out to pharmacy if possible to check drug interactions.
Dr. Nayak, I know one of the most common ones that comes up for our adult patients as in primary care is interactions with inhalers, both steroid inhalers and salmeterol. So the risk with steroid inhalers is concerns about Cushing syndrome. Risk with salmeterol is concerned about QT prolongation with inhibiting the drug. What are your thoughts?
So I think this is something, I think we emailed back and forth about this a little bit. For the steroid inhalers, my feeling, and I'd love to get your input on this as well, is that very little gets absorbed and it's a 5-day course. So the risk is minimal. I have tended to go ahead and use Paxlavid in children on steroid inhalers. I've had a little more caution with the salmeterol only because I think I'd be much more willing to if we had a baseline EKG, but that's something we don't often have. So in that situation, I generally will weigh how high risk the child is. And in the kids who you're going ahead and doing it, you might consider whether knowing if there's any baseline QTC prolongation would be advised.
So in adults, I can just speak on our experience. I agree that I have not been advising to hold any steroid inhalers. I think the risk of Cushing's after a 5-day course of therapy is pretty low. As for salmeterol, we're lucky that a lot of the times we do have a baseline EKG. So if the patient has other respiratory conditions, you're weighing the risk of holding the inhaler versus the EKG. So in patients that have a normal EKG on file and don't have any other reasons to suspect that it would jump, any other interactions going on with the Paxlavid, anything else that could cause it to do so, and who have some sort of severe lung disease, we've been okay with continuing therapy. But it's very much a case-by-case basis.
Right. And a lot of the kids who I've been called about who have been on the salmeterol have been kids who have asthma. In many cases, this has been pretty intermittent, well-controlled asthma where I don't feel as pushed to treat in the first place. There is a question in the chat about COVID boosters for kids who now are eligible with the recent approval versus waiting to closer to the fall. I have been advocating people to go ahead and get boosted because we don't know what's coming. The most common question that I have gotten is, well, will there be a strain specific booster available come fall? And I honestly, the studies are being done in adults right now, but they have not moved into children yet. So I don't have any clue as to when that would be available for even the adult population, much less the pediatric population. What I've been telling people is even if you go ahead and get boosted now, if there is a recommendation, if there's need for a further booster, you're likely to be eligible very close to the beginning of the school year anyways. And if there's not need, you'll be protected through the summer months, and that's wonderful. So I have been pushing people to go ahead and do that. And in fact, I got my 2 youngest boosted this 2 weeks ago. So.
There were also a couple questions. Dr. Cook asked about anything on these 2 that I will not try to pronounce, but I just want to make sure that they're caught on the recording. So it's formatidine, I guess, and
Fluvoxamine is the other one. Yeah.
I certainly have not seen any data beyond the previous data that had been published. And when I was looking at the COVID treatment guidelines, the last I saw was that they were not recommended, like as of very short period ago.
Thank you. And then just another one here on the use of HIV antivirals and Maraviroc. See? Any data thinking that those would be reasonable?
I have not seen personally any data on that. I'm not sure if anyone else can jump in and comment. Based on the mechanism, there's, I would not expect it to be a first line, but I have not seen any data one way or the other.
Correct. I would agree. There are some ongoing, very small sample size clinical trials going on looking at Maraviroc in terms of if it would be effective against COVID-19, but there's been nothing in humans. There's something in a cell culture, but also hydroxychloroquine showed it could do something in a cell culture. So that means nothing. So we, again, the sample sizes are very small. It's like 9 to 60 people, depending on the study. So at this point, would say not effective or we do not know.
So I think it's interesting that question came up because of an online telemed recommendation. So for that individual who raised the question about the HIV antivirals, and if there's any offline follow-up you want to make with us about where that recommendation came from, it might be nice to offer some feedback back around.
It looks like there's a question about ACIP making a recommendation for preference for Moderna and Pfizer. Based on the data, I honestly am not sure. But the comparison of one vaccine to the other vaccine, the data that's been released, and I'm actually involved in both trials, the data that's been released is pretty limited. Pfizer shows pretty good efficacy with the 3 doses, but the follow-up period has been pretty limited. So I fully expect that the efficacy is going to decline over time. Moderna's efficacy was lower after 2 doses with a longer period of follow-up, but there is a plan to go ahead and test administering a 3rd dose to the younger children in the Moderna trial. This has not been initiated yet. It's going to start probably within the next month that we'll start the 3rd dose trials there. So I think it would depend. Both of the vaccines were very, very well tolerated. I can tell you that. Generally a little bit more reactogenicity with Moderna, but I think that's similar to what we've seen in a lot of age groups.
Any other questions, folks? Got a few minutes here. So you can drop in the chat or feel free to come off of mute.
It's a quiet crowd today. I'm not seeing anybody coming off of mute.
That's what I'd say, we're quiet.
Yeah.
Me neither.
I think it's tricky. I know a lot of the practitioners are questioning what they should do in terms of ordering. And, you know, when you're already vaccinating different doses for different age kids, you know, are you going to have both vaccines, both types available? It's tricky. So Jenny, you don't think there's going to be any guidance one way or another coming? It's going to be more just approval or not?
I think there could be, there might be a preference expressed, but I'm not sure at this point. I think that it's hard with Moderna having not having provided data on a three dose regimen where Pfizer has. So I think the 3-dose regimen with Moderna will look great but the testing has not begun yet. Dr. Cook, I see a hand raised from your Yoda.
Yes. So Moderna is also seeking approval for a 6 to 17-year-old dose.
Yes.
And unfortunately, I've not seen anything on how to order that, at least through the state material. So I don't know if you've seen anything, or LJ, in terms of ordering that. Not that we expect, you know, many people in that age group who haven't been vaccinated to get Moderna over Pfizer, but they're approving a big vaccine and it doesn't appear we can get it.
I could speak to the data, but not on the ordering. Sorry.
Damn.
Some of the lack of questions could have been answered by Toby Burchin's comment in the chat, like that people's heads are spinning in this. I mean, it is really, it's a daunting place to be right now with not having community support for vaccination and just sort of like, what do you order, which one, not being sure what's going to be approved. It's a crazy space. So I think what we can just say to the pediatric and family medicine teams who are going to be doing this work is, you know, we will continue to elevate any information that we get, any recommendations. If there's any level of community standard that's going to be, you know, recommended, I think we're all going to be in the same boat together. So we will share what information we get and be open to your questions. And I just wanted to thank the pharmacy team and Jenny for being willing to join us for the session today. Any other questions that people want to lift before we close out? Chad, you want to finish this up?
Sure. I was going to say, even though this was supposed to be like the Empire Strikes Back version of the AHP COVID call, it turned out to be the COVID call 2.0. But we will try to start working in more other details as time goes on. Obviously, just being responsive and trying to be attentive to the state of the world and making sure we're answering any questions that come up. And God only knows where we'll be 30 days from now with COVID. So Hopefully it'll be fading away and we'll be able to talk about any number of other things. It'll be more fun. But for now, we will plan to get back together in 30 days time unless something exciting happens, at which point we will reach out electronically as we have. And if people have questions, please feel free to send them. We'll try to get answers sooner if we can, or at least compile interesting topics and devise an agenda so that we'll be ready for next time. But thanks for joining, and hopefully we can decrease the spin rate of everybody's head for the next meeting.
Thanks so much for having me.
Thank you. Take care, everybody. Have a good one.
Good day.
Bye-bye.
Bye.
Have a good one.